Hi, and welcome to our Research in Progress webinar series. I'm going to go ahead and get us started here today because I know we've got a great presentation headed our way, and I want to make sure that we save time for questions at the end. So I'm going to kick us off here with our welcome, and then I'll hand it over to our presenter, Beth Weiss from the Sidewalk Project, who is serving as the principal investigator for this project. If you are new to our Systems for Action Research and Progress webinar series, I can just orient you a little bit to why you're here today and who we are. But we at Systems for Action are a national research program office funded by the Robert Wood Johnson Foundation. We have been funded since 2015. And one of our main goals here at Systems for Action and one of our main activities is to develop and release annual funding opportunities, soliciting ideas for novel and innovative ways to align systems. And the systems that we are most interested in at Systems for Action are the medical, public health, and social service systems. So all research projects funded through us have some way of aligning either the delivery or financing mechanisms across these three systems. And we want them to research how aligning these systems can improve health equity. And more recently in our funding opportunities, we're really interested in how aligning these systems can disrupt systemic racism that has been embedded within each one of these systems. So today you are hearing from one of our newer projects that was funded from a funding opportunity that we released in early 2025. And this cohort of 5 projects began their projects in November of 2025. So this is the first time that you're getting to hear about this research project and what they have planned to do and what they've done so far since November and what their future plans are in this 12-month pilot study. And you will have a chance to hear from this researcher again, probably later in the year when the project is closer to being completed, to learn a little bit more about what they have learned and what they've done and how they're learning about aligning the systems that they have planned and prepared to do in their Systems for Action research project. So just a few housekeeping items before I hand it over to Beth. This Research in Progress webinar series is recorded. So we will make sure to send you the recording of this presentation alongside the PowerPoint slides and any other resources that are shared during today's webinar. The only other item is that we will save time at the end of today's presentation for questions and answers. So if you have any questions that pop up anytime during the presentation today, please locate the Q&A box at the bottom of your Zoom screen, pop your question in there, and we'll make sure that we have time to ask Beth after they're done presenting. So with that, Beth, I'm going to go ahead and hand it over to you. And I think I covered the agenda slides. You can probably just start with your presentation slides. There we go. Thank you so much for joining us today, and I'm excited to hear what Beth's going to share.
Thank you. Thank you, Carrington. Yes. Hello, everyone. My name is Dr. Beth Weesey, and I'm going to talk to you today about technology-supported peer connections to reduce overdose fatalities. And just a really quick bio about me. My work aims to influence future drug policy with novel evidence-based research that also advocates and empowers people who use drugs to feel safe and prevent fatal overdose. My expertise as a scientist built on my prior lived experience navigating chaotic opioid use, and my training in neuroscience, pharmacology, psychology, philosophy, and the mechanisms of breathing have helped to build on my lived experience. During my PhD, I was part of co-founding a grassroots harm reduction nonprofit that delivers safe supplies to people who use drugs, and it's called Church of Safe Injection Tucson and is still currently operating. After completing my postdoctoral studies at UCLA, my current work occurs co-housed at the Sidewalk Project in Los Angeles under my community-driven research institute, Transformative Harm Reduction Research Institute of the Voices, or THRIVE. And before we get into the presentation, I want to take a moment to make a land and labor acknowledgement that we recognize our location on the ancestral land of Tongva, Tataviam, Serrano, Quiche, and Chumash peoples, acknowledging their ongoing stewardship and the harms of settler colonization. This acknowledgement honors the elders and descendants of these tribes, recognizing their ongoing stewardship of the land and waters, and acknowledges the harms caused by settler colonization, including land seizure, disease, subjugation, and other injustices. This acknowledgement is a commitment to truth, healing, and reconciliation with the First Peoples. We also acknowledge that our nation has benefited from the free and slave labor of Black people and people of color. We recognize the forced labor and debt owed to Indigenous peoples, Chinese immigrants, and Japanese Americans for their contributions and the exploitation that they faced. We acknowledge and remember those who did not survive the Middle Passage, those who were beaten and lynched, and those who are still suffering while fighting for their freedom. We honor the legacy, knowledge, skills, and human spirit that persevere despite violence and white supremacy. This work would not be possible without the prior contributions of immigrants. And so now to get started, I'm going to talk about the opioid epidemic, the overdose epidemic. And beginning during the 1990s, fatalities from opioids have remained a public health epidemic with over 800,000 people who have died from an opioid overdose from 1999 to 2023. That reached over 200 people a day in 2023. And while numbers have declined, it still remains over 140 people every day who still lose their life to a preventable death. And so, what about the numbers of opioid-related fatalities locally? We saw those national numbers. Well, these are the last 7 years of overdose fatalities in LA County. And while these data are helpful, they can lose really important spatial and geographical information because of how large LA County is. And we can see that in the map to the right. And so if we zoom in a bit further to look at the Skid Row community, which is highlighted by the blue trapezoid to the right, the effects of rising opioid-related fatalities are felt hardest in the 3 zip codes of the Skid Row neighborhood. And that's 90013, 90014, and 90021. And so the demographics of the Skid Row community, a historic epicenter of houselessness and home to a predominantly aging in place Black and Latinx population that's navigating overlapping health crises, substance use, and unstable housing, are displayed here, where a median age is of 52 years, about 20% being veterans, and overwhelmingly being a male populated area. And rates of fatal overdose rise disproportionately in Skid Row compared to the rest of LA County from 2018 to 2021. As we can see displayed here, where pretty massive jumps took place in each zip code. This increase in overdose rates has an impact on EMS as well. The increasing volume of 911 calls in Skid Row has resulted in increasingly delayed response times, and per a Los Angeles Fire Department paramedic, regularly taking up to as long as 20 minutes. This is a problem when it comes to successful overdose response when minutes count. So how does this impact other systems of care involved in overdose response and post-overdose care? So delayed response times can have a big impact on recovery outcomes following an overdose experience. This has an impact on the perceptions of people who survive an overdose by EMS, and they can also have an impact on EMS burnout if they are transferring the same person over and over again. And we can see the drastic difference in emergency department visits from the zip codes of Skid Row compared to LA County as a whole. We also know that this increase in emergency department transfers has an impact on capacity of people who work in the emergency department, given that a lot of people who are transferred end up leaving against medical advice since the emergency department is not designed to be a post-overdose monitoring facility. And many overdose survivors spend their time in the waiting room due to this overwhelming demand for other emergency services that are taking place there. This was a main driver in efforts among community overdose response teams to step up and fill this gap. or at least to find a way to support people experiencing an overdose event until EMS could arrive. And so community overdose response teams can have a major impact in localized areas. And that's what we can see here. Despite overdose fatalities rising in LA County, the rates of fatal overdose per 100,000 people in Skid Row zip codes went down in 2022, the same year that the Sidewalk Project opened its first fixed site, as seen with the thumbtack on the map. And the reduction in overdose fatalities wasn't the only positive impact from the Sidewalk Project's fixed site location. It also seems to have had an impact on post-overdose emergency room visits in the 90021 and 90014 zip codes. So who is the Sidewalk Project and what exactly is it that they do? The Sidewalk Project is a lived experience, women, and peer-led organization that aids unhoused, drug-using survivor and sex worker populations, providing residents case management, including medical care and housing linkages, and system navigation services. Our street team provides direct services, including crisis response, system advocacy, wound care, job placement, medication for opioid use management, and creative community resources for mental health, in addition to harm reduction services like safe use supplies, connection, and education. And so, what are harm reduction services? Harm reduction as a form of treatment and prevention has been utilized for decades for a vast number of public health epidemics and issues. And many times they include a multimodal approach. And so today, our most successful harm reduction strategies that are operating across the country are syringe service programs. These programs provide more than just naloxone and sterile supplies to people who need them. They also create a network between the individual who is using substances and the syringe service volunteer or staff member. Syringe access programs can also be a location to offer additional resources that the individual who is using substances likely did not even know existed. So by meeting people where they're at, harm reduction peers can educate people on safe use practices like never using alone, or go slow, use low when consuming from a new batch, as well as how to use naloxone while building connection with people who use drugs. And harm reduction isn't just about the supplies provided. It is also about meeting people's basic needs and helping them to gain access to the services that are best suited to support them. In 2025, we served almost 8,500 people. And while over 28,000 smoking devices and just under 30,000 needles were distributed, over 34,000 used syringes were turned back in. This has a communal impact, reducing the number of accidental needle sticks and chances of someone reusing a syringe after it's been discarded on the street. Additionally, sleeping bags, blankets, menstrual items, hygiene kits, and wound care items rank at the top of items distributed, as well as over 5,000 meals and over 18,000 condoms. And the most heartwarming impact was seeing 170 of our participants receive housing, and 95% of our participants who started on HIV care retained in care 6 months later. By meeting people where they're at, reduces unwanted pregnancies, it prevents the spread of infectious disease, and it supports people to care for themselves. This is how we build connection with people when we support them to meet their own basic needs. Drug checking education is another thing that we offer that is incredibly valuable. This technology, originally intended for testing urine to determine if someone had consumed a certain substance, is now an educational tool to keep people who use drugs informed of the changing drug supply. This is just one of the many examples of harm reduction repurposing existing technology to support and empower people who use drugs. We currently have individual test strips for fentanyl, xylazine, amphetamines, methamphetamine, benzos, opioids, and nitidine, and this list continues to grow. This information is incredibly valuable to confirm if something specific is in your drug supply, but it does nothing to inform the individual of other unknown compounds in the drug supply. In 2025, the Sidewalk Project distributed 2,009 of these test strips. And another way that we can keep people informed is the use of FTIR spectroscopy. This is a powerful technique for identifying and characterizing chemical compounds by analyzing how they absorb infrared light and creates a unique molecular fingerprint to reveal molecular structures, compositions, and even reaction dynamics. It's widely used across pharmaceutical investigations, polymers, forensics, and food analysis for quality control. It looks at impurity detection and material identification by matching absorption patterns to databases that have already been created. And so, like many other harm reduction techniques, it has been repurposed to better inform people who use drugs. And without this tool, people expecting to be consuming fentanyl would never know about some of the other compounds in their drug supply that they did not ask for. Specifically, xylazine, B-temps, which are microplastics, methamphetamine, cocaine, and even recently carfentanil. Through collaborations with Drug Checking LA, we are able to offer this service every Thursday to our participants. In these situations, people are able to use this knowledge to alter the route of administration or how much they use in order to keep themselves safe. This is especially important when it comes to interactions among adulterants, such as xylazine or other alpha 2 adrenergic agonists, which cause blood vessels to narrow. This effect specifically reduces blood flow and oxygen delivery to tissues, especially on the extremities. Tissue starved of oxygen and nutrients becomes damaged and it eventually dies. This forms these painful ulcers and blackened dead tissue on the extremities of individuals. And then we also have aniline compounds that we are seeing. That's the simplest aromatic amine, and it's a clear to yellowish, oily liquid with a musty or fishy odor. It's crucial in making polyurethane dyes, herbicides, and rubber chemicals. It's toxic by skin absorption or inhalation. And the interaction of these two types of compounds increases the risk of methemoglobinemia, which is an increased concentration of CO2 in the bloodstream and further enhances the wound severity as well as delays healing. And so at the Sidewalk Project, we have begun the process to obtain an FTIR machine. As harm reductionists have repurposed this valuable technology to inform people who use drugs, it has only been validated on one machine, the Alpha 2. That runs about $40,000 to $60,000 to get started. And so through partnerships with Anton Par, we're going to purchase the Liza 7000 for around $28,000 over a multi-year agreement. This reduction in cost not only makes the machine more accessible to other organizations, it's going to serve as a way to validate how this technology can be utilized across machines to increase drug checking access to other organizations across the country. But harm reduction isn't just about education. It also includes access to safe use supplies, including naloxone, the opioid antagonist used to reverse opioid overdoses. It's first discovered in 1961 and used in medical settings to reverse opioid toxicity and manage anesthesia. It started to be distributed by paramedics in Oakland to people who used drugs during the 1980s. And in 1996, Chicago Recovery Alliance started on a journey to make naloxone distribution accessible through syringe service programs and led the way for the widespread distribution of naloxone over the counter and free of charge from harm reduction programs to people who need it most that we see today. Our Tree of Life program was created by Riley, who is pictured here with her dog, Ruby Reversal. And this program staples naloxone to light poles and trees up and down the streets of Skid Row. This has become such a reliable means of ensuring naloxone is where it needs to be when someone overdoses that residents of Skid Row now know to look for light poles when they need naloxone. In 2025, the Sidewalk Project distributed almost 40,000 individual naloxone doses that resulted in over 650 successful reversals. This accounts for approximately 13% of all naloxone distributed within LA County, and it was responsible for about 17% of all successful reversals that were seen. Naloxone is a very easy drug to educate people on how to use. You see someone who is unresponsive, you walk up and you attempt to alert them with a knuckle rub on the chest or above the lip. And then if they do not wake up, you tell them you're going to give them naloxone and then you give it and begin rescue breathing while the naloxone goes to work. The problem with naloxone is that it cannot be a preventative treatment because it doesn't just restore breathing. It cancels out all the effects of opioids, including pain relief, and induces precipitated withdrawal in opioid dependent people. And so it cannot be administered until after the person has stopped breathing, which requires a second person to be present. And as we saw with the rising fatality rates, we know that sometimes that is very hard to have a second person present. And so oxygen and naloxone have become the most valuable tools for overdose response teams that save lives. But overdose response is changing under an ever-changing drug market. Polysubstance consumption and changing adulterants can alter the way that overdose response plays out. I told you about how naloxone can induce precipitated withdrawal symptoms, and now we have incorporated respiratory belts into our overdose response that Bluetooth to our crash cart computer that you can see in the middle photo and shows us immediately when someone starts breathing again. This knowledge tells overdose responders when to stop administering naloxone and just focus on oxygen administration and rescue breathing because the opioid receptors have all been occupied. And so it's important to understand how opioid receptors work in the brain to restore, or how naloxone works on opioid receptors in the brain to restore breathing. Opioid receptors act like chairs at a table, and there's only so many chairs. And so once those chairs are filled up with naloxone, any additional naloxone administered is just inducing further precipitated withdrawal symptoms. And so these belts were designed for use in sports like CrossFit or science classes to understand how to manipulate breathing patterns. But here is another example of harm reduction repurposing existing technology to support people who use drugs to be as safe as possible. And so here we can see how the data display on our crash cart computer with an example of the belt placement. And this work aims to develop effective and equitable interventions to reduce unnecessary harm to the individual experiencing the overdose. It aims to limit unnecessary EMS transport and spending, and ultimately moving toward health equity for all. This reduces excessive naloxone administration and it reduces the severity of precipitated withdrawal symptoms experienced by the individual. Once someone has been successfully revived, they have a choice to go to the hospital for monitoring or to stay with peers to receive post-naloxone monitoring. This allows individuals to remain in their community and obtain information from the peer on additional ways to keep themselves safe while navigating their substance use. This can include alternate routes of administration. It can include education on changing trends in the drug supply, or even referrals for additional services. This intervention also stands to reduce medical debt by reducing unnecessary EMS transport to the emergency room. And so in this example, the individual started breathing again, but they did not regain consciousness. So these data not only helped us responding know when to stop administering naloxone, it was helpful for EMS to reduce assessment time once they arrived. This person had to be transported to the emergency department for further care. And in this event, someone who does require transport to the emergency care, we provide a business card that accompanies the individual to the emergency room and gives the emergency room personnel a point of contact to direct people to after discharge for continuum of care. And so the individual can find out more information on what happened to them during their overdose, as well as collect any belongings that were left behind at the scene. In this situation, we had the person's bike. And so they came by a few days later to pick up their bike and reported to us that they were surprised to hear that they had overdosed, since their precipitated withdrawal symptoms were reduced compared to their past overdose experiences. And so once the goal zone is reached of breathing on their own at least one breath every 5 seconds, and their oxygen saturation is on the rise, a variety of post-naloxone support services can be offered in the form of peer monitoring or observation and precipitated withdrawal symptom management. Survival of a non-fatal overdose can be really hard on the body. And traditionally, you had to continue to interact with the individual to make sure that they do not overdose again as the naloxone wears off. By continuing monitoring with these belts after successful reversal, we can let people rest while we are monitoring them, monitoring their breathing during periods of drowsiness. And then we can talk to the individual during periods of arousal. And so precipitated withdrawal symptoms can be managed with a variety, or they can be managed or soothed, maybe not fully managed, but with a variety of over-the-counter medications, such as Tylenol and Benadryl. And then we also offer a cannabis pre-roll to individuals. This is also an excellent time to educate people about the metabolization of naloxone so that way they know and understand when they can use again and make sure that they have naloxone and know how to use it in the event they need it in the future. And so while providing peer monitoring, staff can inform participants of additional possible support that's available, whether it's chronic condition management, HIV and Hep C testing and treatment, PEP and PrEP services, wound care, counseling, LGBTQ plus services, medications for opioid use management, addressing health needs that are caused by housing insecurity and disconnection from primary care, as well as healthcare linkages for reproductive health and safe sex, pregnant people support, pelvic health therapy, and STI testing and treatment linkages. Information that is gained about the participant in these sessions comes from open-ended and non-judgmental questions that are really aimed at understanding how best the participant would like to be supported. It can also be a time we can collect self-report questionnaires on the experienced withdrawal symptoms, perceptions of self, and overall satisfaction with our protocols for future refinement to collect the experiences of participants if they're open to sharing them with us. And so to determine the feasibility of the project, we are collecting self-report information from participants on their experiences with the intervention, perceptions of self, and sustained engagement in services. We also hold community advisory meetings with overdose response teams and EMS to determine how we can set up meet and greets to improve situations in the field between the two groups and if burnout among EMS is being reduced or buffered. Finally, we will evaluate the current cost of EMS transport after overdose reversal to compare with post-implementation of this project to determine if it will be possible to redirect some of that cost savings into creating a sustainable funding source for this project in the future. And so future directions of this project includes hopes for the future will be to develop a protocol that is user-friendly and easy for other organizations to implement. Partnerships with MLK Hospital and their Sobering Center have also begun that will provide a second additional location near South Central LA where peer monitors can conduct technology-supported monitoring following successful reversal of an overdose. Additionally, buildup of the program would benefit from additions to the belt software that would allow for alarms to alert peers of any changes to breathing behavior, as well as increase accessibility to the belts through product production that's available on a sliding scale so the resource can be made available to underfunded programs doing this work on the ground. We will also look at additional ways that the belt can be utilized to support people who use drugs, such as in an overdose prevention setting, to inform peers immediately if breathing stops. And finally, to maintain follow-up with participants and future programs on their experiences with this technology to continue and refine how we use the belts in a way that continues the path to better health equity for marginalized populations. But what if there was a way to prevent overdose before it happened? Ideally, this would be a non-intoxicating medication that could be taken alongside opioids to protect against their depressive effects on breathing. It would preserve or even enhance their pain relief. It would be widely available and maybe even improve the efficacy of naloxone in the event an overdose were still to occur. Well, a new field of research is showing promise at preventing overdose by counteracting the depressive effects of opioids on breathing. And so this is work from my postdoc appointment at UCLA. And here I used whole body plethysmography to record breathing behavior of awake and freely moving mice. And in these awake mice, I pre-treated them with saline or vehicle, followed by a high dose fentanyl injection of 50 mg per kg that depressed breathing approximately 50%. And when I pre-treated these mice with naloxone and then gave the dose of fentanyl, we can see that it mitigated or prevented that effect. And when I pre-treated with a high dose of CBD that was equivalent to Epidiolex, which is an FDA-approved medication, it was equally as effective at preventing respiratory depression as naloxone was alone. And when I gave them both at the same time, I was assuming to see an additive effect of the CBD plus naloxone. But since naloxone and CBD both prevented respiratory depression on their own, I could not determine from these data alone if there was an additive effect or a synergistic effect of CBD plus naloxone. And awake mice do not experience a persistent apnea in the same way that humans do from high dose fentanyl. So, to really get at that question that I had from the prior slide, I wanted to evaluate if our pretreatments could increase the fatal fentanyl dose or prolong the time to an apnea onset. And so for this, I used a model of overdose in urethane anesthetized mice. And the reason I used urethane anesthesia is because it preserves breathing behavior of an awake mouse. And then I provided a continuous intracranial ventricular or ICV fentanyl infusion at 100 nanograms per minute until breathing stopped or persistent apnea occurred. And so this allowed me to evaluate these treatments for impact on survival time. And so in this model of overdose, when I pre-treated with saline or vehicle, a persistent apnea occurred within 9 minutes, or 900 nanograms of fentanyl. And then when I pretreated with naloxone, we can see how it prolonged the onset of the persistent apnea and increased the lethal fentanyl dose to about 1,800 nanograms of fentanyl. And when I pretreated with the high dose CBD equivalent to the Epidiolex medication that's already FDA approved, I found that it was equally as effective as naloxone to prolong the onset of this persistent apnea or overdose. And when I gave the CBD plus naloxone pretreatment together, it further increased the time to a persistent apnea onset and increased the lethal dose of fentanyl to approximately 3,500 nanograms. And this supports that CBD could potentially increase the efficacy of naloxone and prolong or prevent onset of a persistent apnea. And so, could this be another point of investigation that we could get at using these belts? So, during the Eaton and Palisades fires, the Sidewalk Project Drop-In Center opened its doors as a 24-hour shelter for people evacuated during the fires. There was an outpouring of support with donations from all across the city and county to support people seeking shelter. And this includes a bulk supply of CBD vapes that were donated from a dispensary for distribution to participants. Would we be able to observe any of these effects just by distributing donated product? And so while this question was still unanswered, it really seemed like we were going to need an institution to test this under. So I started one. Thrive, or Transformative Harm Reduction Research Institute of the Voices, is dedicated to centering the voices of people who use drugs, sex workers, and other marginalized communities in harm reduction research and policy. And as a registered 501c3 and structured as a co-op, Thrive hopes to reimagine how research can support communities impacted most by harmful and outdated drug policies. Our mission is to co-create evidence-based, community-led solutions that reduce harm, promote health equity, and challenge harmful drug policies. Through participatory research, policy analysis, and direct collaboration with impacted communities, we aim to shift the narrative from punitive approaches to ones that are rooted in compassion, science, and justice. And so, as of currently, Thrive is co-located with the Sidewalk Project to support data collection to achieve these goals. And so, initial observations have begun with participants prescribed opioid medications. And in this observational timeline, a baseline is obtained at least 6 hours after the last dose of opioids and prior to consuming the next dose of opioids. Data collection is obtained by measurements of force and time-based at 100 samples per millisecond for 10 minutes. And so approximately 30 to 60 minutes after consumption of the prescribed dose of opioids, another recording is collected. The participant is free to consume as much of the CBD vape as they want, with an average of 2 to 5 puffs being consumed during this period, and after which a final recording phase takes place. Now, as this is very, very preliminary, the variations in time occur due to this being an observational data collection technique. And this participant I'm about to show actually works at our center and oftentimes becomes busy with work or has other obligations that come up before the next recording, which is why they can sometimes be delayed or unable to be obtained in those situations. And so these are some of the preliminary observational findings. And while these results are very preliminary, they support a role for CBD in breathing preservation and overdose prevention. the hydrocodone that it produced an expected rate of respiratory depression that was then reversed following CBD vaping. We would still need to collect more N and investigate CBD prior to the opioid consumption to see if it can maintain this prevention of respiratory depression. But if it's maintained, this could revolutionize overdose prevention if people are able to utilize CBD as a prophylactic to an opioid overdose. And so, future directions of Thrive. Thrive hopes to continue projects like these that improve well being, promote drug user health, and rewrite harmful narratives about people who use drugs through research collaborations that are rooted in respect and autonomy. We hope to establish a foundation of funding that is not beholden to the current federal governmental interpretations of the value of our lives through private donors, foundational grants, and collaborative projects. We hope to center the questions of the communities most impacted by this research while also offering skill sharing and educational pathways for people who use drugs to be a part of the work and build their own skill sets for future employment and involvement in these projects. We look to continue these conversations and efforts on pathways to increase education and dissemination, as well as research expansion efforts to other organizations doing this work. And this will hopefully be how we can build and strengthen a pipeline for science to the streets and a returning pipeline back to the bench again. And so, with that, I want to thank the Robert Wood Johnson Foundation for funding this project, all of my colleagues at the Sidewalk Project for believing in my work, the Los Angeles Fire Department and EMS for being such eager partners striving for better ways to support and treat their patients who use drugs, the AIDS Coordinator's Office of LA, who funded the initial pilot project, SAPSI for their support in improving healthcare for people who use drugs, Drug Checking LA for their longstanding support to inform people who use drugs on what is in their supply, Mockingbird Analytics for their support in grant writing, and our fellow overdose response teams in Skid Row, Blue Hollywood Street Sanctuary, and Homeless Healthcare for their collaborative support to meet people where they are at with compassion and community. And with that, I can take questions.
Thank you so much for that presentation and letting us all in alongside you as you're doing this research. It's extremely important. I do see that some questions have been entered into the Q&A box, so I'm going to go ahead and start asking some of these, but this is the open call for anyone else. If you have questions about this research project or the future of this research or how to support, feel free to enter that into the Q&A box and we can ask Dr. Beth. So the first question I see here is from Joanne, which is how many people chose to go with EMS, peer, or neither after an OD?
So we have been able to utilize the belts for 5 overdose responses thus far. Um, 2 of the people had to be transported with EMS because they either did not regain consciousness, like the one that I mentioned in the talk, or the other one who had some cognitive impairments that were beyond the services that we could provide. But of the 3 individuals who were successfully reversed and able to communicate themselves, they did not go with EMS. They wanted to stay with peers. And so those were able to turn into communication and conversation connection moments that we could connect with those individuals.
Thank you so much for elaborating on that. The next question comes from Ethan, and they want you to comment a little bit on, and excuse me if I mispronounce these, but xylazine and medetomidine.
Metatomidine, yeah. So these are adulterants that are showing up in the drug supply. And that's what I was talking about, how they narrow the blood vessels. Xylazine is a tranquilizer that is used sometimes in veterinary medicine, but is not approved to be used in humans. It causes quite a bit of sedation, I mean, intense sedation. And it's causing issues in overdose response. And medetomidine is also doing somewhat of the same thing. And so this incredible, like this sedation that people are undergoing is what can make overdose response very confusing because you've given naloxone and then the person will start breathing, but they don't regain consciousness because they're so sedated on these additional adulterants. And so without the belts, sometimes it can be incredibly difficult to know that you have reversed the opioid piece of the overdose and know when it is a different substance that is contributing to the sedation that you're seeing.
Thank you. The next question comes from Joanne again, but what ODs are you responding to? Are they coming from EMS or street outreach other? I think you kind of touched on this a little bit earlier, but anything else you want to add?
So, the Sidewalk Project has an overdose response team that can be deployed into Skid Row. It happens when we're doing outreach. It can happen. We've had multiple overdoses that have literally occurred right in front of our center. And so then we run out to respond as we have someone who works, we call them, they work the gate. We have a gate when you enter the center, and there's a staff member posted at that gate at all times when we're open. And so they have an ability to call for the overdose response team if they can see something that goes down. Other instances have been when we're on outreach or times when people have, you know, yeah, so either on outreach or because we've been alerted by the community that there is an overdose taking place in Skid Row.
Great. Okay. Next question comes from Tahana. I hope I'm saying your name correctly, but the question is, what is your vision for work and thrive in the next 5, 10, 15, 20 years? So tell us about what you're hoping the future brings.
Oh, okay. So these are big, big, I'll go for the big, big dreams. With all, all the planets have aligned and Pluto's been reintroduced as another planet kind of scenario. Yeah, so my big dreams would be that Thrive can build out these programs in a way that we can also develop and produce the belts in so we have AED pads that go on if somebody has to um, use an AED machine. And so if we could reproduce these belts into like either a sticker patch that could also read the force when someone starts to breathe again in a very low cost way that can Bluetooth to an app. If we could produce them in a way that we could mass distribute them, we could get them out to people who utilize the safe spot, never use alone line, where they could put one on, connect it to the app. The operator could also then pull up this app and see them breathing in real time, would provide additional support to be able to offer overdose prevention services. They could also go out and overdose kits, for people who do have someone to be around while they're using, can use these, to help know when an overdose is occurring. And then if we could also expand that into being used by, say, EMS, because a lot of EMS providers use visual breathing, like they visually determine if someone is breathing or not, or listen. They don't necessarily always use some sort of breathing monitoring device. But if we could develop these patches, say, in a way that EMS would also take on utilizing these belts, and they don't have any tracking or patient information attached to them, then if they're put on by EMS or put on by a peer, they could also be used through all of these services during overdose response, where if EMS takes someone to a sobering center or to an emergency room, they could utilize that same patch to continue monitoring that individual. And if this dream could come to reality, EMS and hospitals could absolutely foot the bill for most of these patches, offering an opportunity to have sliding scale or no cost distribution of the patch to harm reduction organizations or peers on the ground for individual monitoring. And then that any funds that would come back in through EMS or the hospitals utilizing these could, potentially be turned around to offer additional grants back to harm reduction organizations as unrestricted funds to do the work that we know needs to be done to prevent overdose. The other dream of this organization of Thrive would be to be able to so I hold a patent for all known cannabinoids and their metabolites and overdose prevention, which would include CBD in this way. And so in a perfect world, there would be pharmaceutical companies that would come to develop the correct formulation and route of administration of CBD that could be utilized by people who use drugs. But because I own the patent, they would have a limited profit margin. And if they, don't adhere to that, they would need to then either be paying back in or providing those medications to be redistributed to those who uh, are not able to access this. And again, any profits that could come from such a project would then be redistributed or turned around as grants that could be offered to more harm reduction organizations to continue this work.
You have big goals and sort of ideas that you want to work forward to in the future. So if any of you want to support or stay engaged with what Dr. Beth is doing moving forward and want to know what Thrive is up to, her email address is right here on the screen. So make sure that you grab that and send her an email later if you want to connect on this. I'm going to kind of bounce around because I see some questions coming into the chat as well. So I'm going to ask a question that came in from Kelly, which is sort of two questions. And one is, how do you track reversals? And then they also mentioned that they're from Maryland. So they're curious about how far geographically your team sort of operates and if there are any duplicative programs out there that are doing anything similar to you.
Yeah, that's a great question because, like, in reality, we know that our overdose tracking is probably underreported. So, when someone obtains naloxone from one of us at the center, we always ask, did you have to use the one you had before? And they will either say, no, I gave it away, which is pretty common, or they'll say, yes, I did. I'm so glad I had it, or they'll say, I never had one, which then tells us that we also need to offer training. Um, but yeah, there's naloxone available all over the Skid Row community. Like I mentioned, with stapling it to light poles, as well as we have a naloxone box right out front of our center. But so we track the successful reversals that are reported back to us by our participants. And so the Skid Row community, you asked where it's located. Skid Row community it's a small neighborhood that does cover three different, parts of three different zip codes. But it is not, it's a very fairly small area that we are serving, which really speaks to those localized impacts. I'm not 100%, like I'm not sure of another location that is doing the exact same work, but I would imagine harm reductionists are really resourceful and scrappy. They find ways to have really, really positive impacts in their communities. So I would imagine that there are probably other forms of such a program that could be taking place around the country, but I'm just not aware of them.
Okay. Kelly also put in the chat, sorry, I was asking if they work with organizations as far away as us to duplicate what they're doing.
I would love to.
Sounds like y'all can connect after this, perhaps. I think we have time for one more question before we end. We've got 2 minutes left. I'm going to ask a question that came in from Ethan, but I'm going to sort of add my own question to this because I think it's related. But that question here is, what do you say to the prohibitionists that claim that this kind of intervention merely facilitates continued addiction? I think many harm reduction organizations and people that work in this field experience that no matter what. And I think my question that I want to tack on to that is what relationships that you've built with other systems partners do you feel kind of help you push forward your agenda with harm reduction?
Absolutely. This is a great question. It comes up, all over and repeatedly. So one thing that I always like to remind people is that substance use doesn't happen in a siloed way. Like substance use is oftentimes just a symptom of something else that's taking place. And if someone can't get their basic needs met, they're going to exist in a state of survival. And substance use can oftentimes be a part of that state of survival. And so I often argue that if we hope to intervene with or alter someone's substance use, which is their choice, it shouldn't be up to us to decide what they get to use and when they get to use. Um, but we need to meet their basic needs first. We cannot expect such a life change out of someone, such a massive change out of someone's behavior without ensuring that they have their basic needs met. They know where their next meal is coming from. They know, um, they have housing, they have opportunities for skill building or for financial support. And so I would push back on anyone who just looks at substance use alone and say that we need to zoom out. We need to zoom out and look at we need to look at the full context and how we can support people, because it is oftentimes so much more than just the substances that are being used.
Absolutely. I think that's a great way to wrap up. I know that we do have some questions in the Q&A box and in the chat that we did not have time to address. I will make sure that Dr. Beth has these questions and we can include those responses in our follow-up email along with the recording and the slides from today. But thank you so much for coming and presenting, and thank you to everyone who joined the presentation. And we hope you have a wonderful rest of your Wednesday.
Thank you,
Bye.
everyone.